Welcome to Bioethics in the Margins. We are a group of bioethicists from different institutions across the country. This podcast represents our views and those of our guests, but we do not speak for our universities or medical centers or for bioethics organizations. Our mission is to bring marginalized topics and voices into the bioethics discourse. This podcast is hosted by Dr. Amelia Barwise, Associate Professor of Medicine and Biomedical Ethics at the Mayo Clinic, and Dr. Kirk Johnson, Assistant Professor of Justice Studies and Medical Humanities at Montclair State University. Please enjoy this conversation.
Well, welcome to another episode of Bioethics in the Margins. And we're always excited to meet and do our guest interviews. But this month we have a really, really special guest. Today we're going to be chatting with Dr. Elizabeth Chuang. She is the founder and executive producer of Bioethics in the Margins. And over the last 5 years, she's been leading us. This was her brainchild. And she's been an incredible leader over this time. So usually she's quietly in the background doing multiple tasks that no one really knows about except for her. But today we want to spotlight her incredible research work and her other work that she's doing outside the podcast. So Dr. Chuang is a professor of medicine, epidemiology and public health and family and social medicine, and she's the director of the Montefiore Einstein Center for Bioethics. The centre provides bioethics education, research and clinical support for Montefiore Medical Center and the Albert Einstein College of Medicine. Dr. Chuang joined the faculty in 2013 after completing fellowship in hospice and palliative medicine, and she joined the Bioethics Centre in 2018 and became the director in 2023. Dr. Chuang's research interests include improving clinician communication with patients and families facing end-of-life choices, ethical approaches to learning healthcare systems, ethical implementation of artificial intelligence in healthcare, approaches to triage during disasters, and community engagement in research and clinical ethics. Dr. Chuang also enjoys teaching medical students, residents, fellows, and faculty principles of bioethics, research ethics, and approaches to emotionally difficult communication tasks. So you're very welcome to your podcast, and it's fun to be able to talk about your work in more detail. So thanks for being here.
So first I have to say that all of the views that I will be expressing today in this podcast are my own, and they do not represent any organization that I work for or that I am affiliated with. Yeah, I have to have one small correction, which is I like to think of myself not as the founder, but a founder, because it truly was a group effort, and it couldn't happen without the whole team really thinking together about how to structure the podcast and then carrying it for so many years. So thank you so much for having me on and for all the work you do all the time.
So a lot of your research work focuses on how racial bias affects healthcare for Black patients. So how did you become interested in this topic?
So this is really something that I've been thinking about for as long as I can remember. I grew up in Poughkeepsie, New York, which is a small city. And I went to the City of Poughkeepsie Public School District. And it was then, and it still remains today, it's serving a student population that's about 75% African American. So I grew up as a white kid in a school that was majority African American. And I'll say that, I say that not to say that I was inside the community, because it really was very socially segregated at that time. So I spent the majority of my time with, the 30 some odd other white kids in the class, because unfortunately it was a pretty segregated environment, I would say. But what it did do was it allowed me to really observe things that I wouldn't have known about otherwise if I grew up in a different kind of situation. And, first of all, I observed the differences in what we had access to at the school that I went to and the surrounding neighborhood school or surrounding area schools in the county. And, I noticed some structural inequalities there, which now I have the language to talk about it that way, but I didn't have that language when I was a child. And I also saw the way that, we were subtly treated differently in school. And I'll give a couple of examples, which is, I spent a lot of time in the guidance a guidance counselor's office in high school because I was an exchange student, so it made my schedule really complicated when I came back. So I was sitting there for what seemed like many hours, but I would see kids coming in and out with different issues, and I would notice, if a white kid came in and said, "Hey, I'm really struggling with honors math," or whatever, it would often be a conversation about, okay, well, how can we get you a peer tutor? What can we do to support you? Let's, continue. And if a black kid came in with a similar kind of question, it would more often be like, okay, well, let's see how we can rearrange your schedule to put you down into the, to the less difficult track there. And I don't think anybody was, intentionally being harmful, but it's what got me interested in how all of these differences kind of together can shape what somebody's life looks like and have profound effects. And I've really been grappling with those questions for my whole career. When I came into palliative care fellowship, I started to notice that, and I work here in the Bronx where we're serving, most of our patients are either Hispanic or Black, and I noticed that we get consults about patient and family who were difficult or, in denial, or they were just, the primary team was just having a lot of trouble communicating with them, and we would go and see them as palliative care and kind of sit down and really get to know the patient and the family. And I would see some of the emotions were, grief, shock, some anger, but mostly shock. And when we processed those emotions, it wasn't any different or more complicated than taking care of, any patient or family. But I noticed that the emotions that were being displayed were interpreted differently by clinical teams sometimes based on patients' race or ethnicity. And it triggered, my memory of the differential treatment that I saw growing up. And that's really become my career focus, is kind of figuring out those dynamics and those conversations. So one of my experiences early on as a palliative care fellow, I was a new fellow. It was August. I had just started, pretty green. And we had a patient in the ICU who was a young patient in her 50s who was in multi-organ failure. And it was clear that she wasn't going to survive. She was getting worse and worse. And so we were having a goals of care meeting with her family, and her decision makers were her adult children. And because she was so young, they were pretty young for to be grappling with those kinds of decisions. Or adult children were in their 20s and 30s. And so we went in to meet with them. We had a conference room, and they're all sitting around a table, and we kind of march in as our palliative care team. And as I was walking in the door, I noticed her son, who was sitting kind of across from us, and he was sitting there, and it was August, so he had a tank top on. He had tattoos up and down his arm. He had his arms crossed. He had his baseball cap over his head and his arms folded. I couldn't see his face. And as I was walking through the door, I had this instant thought in my head, which is, man, this guy looks angry. Like, this is going to be a hard conversation. He's going to say things like, what are you doing to my mom? Why are you're killing her? If she was at Columbia, they would be able to save her. And this is just going to be really difficult. And I should say this was a Hispanic family. And so luckily we did our palliative care thing. We all sat down. We introduced ourselves nice and calmly. We went around the room, asked the family to introduce themselves. And when I came around to the room to this young man, he picked his head up, and I saw immediately that the reason he had been sort of hiding behind his baseball cap was he was crying. His eyes were red, and tears were kind of flowing down his face. And what he actually said was, "Thank you so much for taking such great care of my mother. I know you've done everything that you can for her, and I'm so grateful, and I just want her to be peaceful at the end." So he said the exact opposite of what I expected when I walked in the room, and I realized that that's unconscious implicit bias. There are different ways of interpreting his body language. I interpreted it as anger based on his age, his gender, and possibly his ethnicity, and the assumptions that I had made about this young man. And I thought to myself, like, where did this come from? I don't want to be this person that's judging or stereotyping people. Like, I was embarrassed. I was like, why, where is this coming from? And that got me really interested in, it resonated again with my experiences as a child, and it got me interested in this idea of like, what's out there in the culture that triggers these automatic assumptions in our brains. And it happens, it's not because we're bad people. I like to think I'm not a bad person, but it's because we're immersed in a particular culture, and we make those associations automatically.
That's amazing, all that background. And you then, in 2017, you actually looked into how palliative care services were offered to Hispanic and Black patients. And you described sort of primary and secondary palliative care referrals. So can you sort of tell us about that study and what you found, and those sort of differences between primary and secondary referrals and what that means?
Yeah, so maybe I'll start with that as the first question. Is, in palliative care, sometimes we talk about primary palliative care and secondary palliative care, or primary palliative care and specialist level palliative care. Just like you would say, every generalist physician should be able to treat basic cardiovascular issues like hypertension, but if it becomes more complicated, then you refer your cardiovascular issue to a cardiologist. So it's the same thing with palliative care. So we think that generalist physicians, that internists, hospitalists can have basic goals of care discussion and do advanced care planning, manage simple symptom management issues for patients who have serious illness or facing end of life. But if there's more complicated communication needs or symptom management needs, that's when they should be referred to a specialist team of palliative care clinicians. And so that's what we mean by primary palliative care versus specialist palliative care. And so this study came out of, there's a lot of literature out there suggesting that Black patients receive more life-prolonging and less comfort-oriented care at the end of their lives. So we set out just as a beginning point to see what the patterns were like in our large healthcare center, including 3 major acute care hospitals in the Bronx. And we were able to look at all of the admissions for a single year. And first we created a measure of palliative care need because we didn't want to look at obviously all the patients. So we looked at previous literature and came up with a list of criteria of okay, these are the patients that we think would have some kind of palliative care need, whether it's primary or specialist level. So first we looked at all the patients who died or received CPR during admission. Then we came up with a score of patients who had multiple comorbidities, had things like the use of life support like vasopressors or mechanical ventilation, had prolonged hospital stays or prolonged ICU stays or multi-organ failure. So we created this list of criteria and found the patients that we thought had a palliative care need. And then somewhat surprisingly, we found that Black and Hispanic patients were actually more likely in a comparable clinical situation to receive specialist level palliative care, either through our palliative care consultation service or in our inpatient palliative care unit. And that was sort of surprising based on just the overall literature saying that minoritized patients don't receive palliative care at as high a rate. But what we did find was that the primary teams were actually less likely to have documented a goals of care discussion with these same patients. So to me, thinking back about, based on my clinical experiences and based on sort of thinking about unconscious bias or how we may unintentionally treat people differently, it seemed like the primary teams maybe were feeling like there was a level of complexity in those communications with Black and Hispanic patients that they didn't perceive for white patients. And so they were sort of bumping it up to the experts and doing the palliative care consultation, which is interesting because obviously, I think it's a good thing for people to get a palliative care team for them. So, it's good that they were getting referred and getting that extra layer of support. And I was still concerned about, maybe this idea that they were getting less of the first touch communication with their primary team.
So some of those results were surprising. Do you think if you did the same study now, there would be anything different in terms of how palliative care maybe has, become more widely available and things like that?
Yeah, I'm not sure. Yeah, That's a good question. I haven't thought about that question before. So we based this on data from, I believe it's now quite old. It seems like just yesterday, but I think it was like 2013. So it's been more than 10 years since we did this paper. I don't know. Yeah, I'm not sure. I think our service here is pretty much providing similar levels of care, and unfortunately, I don't know that our needle has moved that much in terms of training, the communication skills training for people who are not specializing in palliative care. I think that's still a gap that exists.
One last question then before I pass it on to Kirk. So you also published a very interesting systematic review on the literature assessing disparities in end-of-life care for Black patients. And you noted that the evidence generated focused on kind of individual beliefs, behaviors, characteristics. And you then used this NIMHD framework to kind of examine where there were gaps in the literature and what things we were sort of overlooking and the fact we were potentially focusing on the wrong things. So can you explain that study? That was really interesting.
Yeah, so this was really a work of passion for me. Frankly, I was a little bit dismayed at the literature that was out there. And I found, for one thing, much like, and I have to put myself in here, much like the cross-sectional study that I just talked about that I did, I found that a lot of people do studies like that on disparities, because if you have any kind of database that has a outcome that you're interested in, a palliative care outcome or any other outcome that you're interested in, and has variables on race and ethnicity, it's really easy to produce a disparities paper and say, hey, look, it was different by these groups. So literally there's hundreds of studies that show that minoritized patients receive more intensive and potentially burdensome end-of-life care when compared to white patients. And so and then there's a much smaller number of people that do more in-depth studies or really try to parse out causal mechanisms. So it seems like there's a lot of people out there doing a one-off disparities paper and less sort of follow-up. And so we aim to do a systematic review. We wanted to look at the literature for the prior 10 years. And just as you're saying, also look at where the attention is focused, because my hunch was that there was a lot of attention focused on on minoritized groups themselves, thinking about health literacy, thinking about cultural beliefs or quote unquote barriers or religious beliefs, and less about, how the healthcare system could be producing these disparities itself. And that's what I really like in the mid 2010s, I think the National Institute of Minority Health and Health Disparities, NIMHD, they had created this framework that looked at multiple domains of causal mechanisms. So they look at healthcare systems, the sociocultural environment, the physical or built environment, and then behavioral and biologic domains. So, their point being that you have to really have a global outlook and look for causal mechanisms across the spectrum, not just narrowly in one or two of those. So that's what we did, and we didn't focus on all those studies that just describe disparities, but we wanted to look for studies that actually made some attempt to look for causal mechanisms. And so we only found 52 studies over a decade that even tried to define causal mechanisms, and even for very few that included interventions that were aimed to improve quality of end-of-life care for minoritized people. Again, many of them, as we expected, looked at patient characteristics, as I said, like such as patient preferences, cultural beliefs, religiosity, health literacy. And unfortunately, a lot of those were fair or poor quality, and many fewer looked at healthcare professionals' behavior or healthcare systems factors. Although I have to shout out, there's a couple of really great articles out there on healthcare systems factors, particularly by folks like Dr. Kimberly Johnson and Dr. Amber Bernardo, who looked at things like community availability of high-quality hospice agencies, and differences in different hospitals' cultural practices. And now, since those my systematic review was done, there's a new generation of researchers like Dr. Deepshika Shana at Duke and Dr. Crystal Brown at the University of Washington, who are really homing in on this clinician communication piece as a key factor. And so the way this sort of fits together in my mind is that there's a lot of literature out there suggesting, although without as robust evidence as we would like, but suggesting that Black patients and families prefer more aggressive care, have poor health literacy, have religious and cultural beliefs that preclude comfort-oriented care. It's no wonder to me that clinicians then have this literature sort of in the back of their mind, and when they go into these conversations with minoritized patients, they're expecting resistance, they're expecting it to be more difficult, and that's exactly what we saw in our cross-sectional data. And so they may just skip the communication or do a more abbreviated communication and go straight to referring to palliative care. And conversely, I always like to point out that there's plenty of evidence that most Black and Hispanic patients actually prefer comfort-oriented care. So in one population-based study, again done by Dr. Amber Bernardo, more than 75% of patients in a population-based study preferred comfort-oriented care. And it was a large study, so there were statistically significant differences between racial and ethnic groups. But the absolute differences were small, and everybody in the study, pretty much, regardless of what group they were in, the majority preferred comfort-oriented care. So if you're going with this idea in your head, you're going to be wrong for the majority of your patients, and you're going to miss the boat making an assumption that your Black patient wants more aggressive care at end of life. Yeah, I was going to say something else, but it escaped. Maybe it'll come back in a moment.
No, absolutely. And no, this is really important work because it really tackles many factors you mentioned of social determinants, cultural competency, communication, convictions of one's particular culture and, religious beliefs. So there's many different factors that you mentioned that to consider. And, we never should assume, right? That is, I guess, the crux of it. We do have the research, but of course, every patient is different, so we can't or ought not to apply research to different, individuals' patients, because individuals' patients are their own individuals, and usually they always break the mold, right? They always are completely opposite of what a particular research study might conclude. So you're doing, well, I told you personally, but since we're being recorded, I'll say it again, you're doing excellent work. And really needed work in order to better serve people of color, patients of color. So we talked about the past and currently what you're doing now. Let's look a little bit into the future. And what worries you about the future of health disparities research? And do you have suggestions based off of your experience for researchers who are doing this particular type of work?
Yeah, thank you for that. So, I would say that the mid-2010s were actually a great time for health disparities research. Again, the NIMHD created this framework that I think was really, really important. They encouraged a broader view of health disparities and really moved away from this deficit model of disparities that I feel like, are entrenched in often, that sort of says, okay, well, whatever the field is, whether it's palliative medicine, whether it's heart disease, whether it's cancer, looking at two different populations, say, well, this population has worse outcomes from that population. So, sort of what's wrong with this population that they don't look like that population, right? And is it, their health behaviors? Is it their diet? Is it their education level? And that's sort of the deficit model that we are often entrenched in. And so I feel like there was a big movement to sort of pull us out of that deficit model and into a broader, more structural model, looking at other causal mechanisms, what barriers there are in healthcare systems and in the environment and in interpersonal interactions that are preventing some people from flourishing. And unfortunately, I see a lot of the movement now to exclude certain words from research, to deprioritize looking for reasons for disparities in those structural and interpersonal interactions is really kind of pulling us back into the deficit model. And I think we do go into cycles with this, right? That this has happened before over time, where we make some progress and then we get pulled back into the space that's frankly not as productive in terms of getting at root causes and really improving people's lives. And so I think for folks who are in this space doing this work and really working on structural racism, the physical environment, and implicit bias and communication, all of these factors, I think it's really important that we not lose ground during this period, not forget the things that we had learned already, and do whatever we can to continue to do the work, even though it's in a really funding environment right now.
Oh yeah, no, absolutely. And before we go into our next question, I think, of course, your work is really important, but also to really be mindful of when we deal with different particular populations on outcomes, but also causes that shape those particular outcomes in general. Obviously, that's connected to the social determinants of health, but your work really emphasizes that, I think, that like, okay, yes, we know about the outcomes, we know that there's disparities, right? But we really have to really hone on to what are causing these particular disparities, what social dynamics are in place, and your work is really aiding in that particular process to see if we could, if not prevent, at least try to alleviate as much of these ills possible to have the best healthcare outcomes for different populations or unique historically marginalized populations as well. So in that particular vein, I want to shift a little bit to public health ethics. Of course, we know you're an aficionado in palliative care, but noting during the COVID-19 pandemic, your research did shift to issues of public health ethics. And in what ways does bias show up in disasters such as a global pandemic? Not to, put answers, but I know that, Asian hate, API hate, granted, because of individuals who might look like a particular certain way. And of course, the political dynamics of that particular time frame, there were, different groups that have been unfortunately targeted with the understanding or this nomer that, it's their fault that COVID-19, the coronavirus has spread all over not just our country, but the world. And I'm sure historically, there have also been other examples of that as well. But yeah, in what ways do you think bias has shown up in the recent pandemic in the COVID-19 era?
Yeah, so as you know, I'm sure we were very hard hit here in the Bronx with the COVID-19 pandemic. I think we were one of the hot spots in the country. We saw unfortunately, many more deaths than most other places in the United States. And it's really hard to overstate what that was like to be here in March and April of 2020 and to just lose so many people. We saw basically whole families get sick together and almost be wiped out. It was, I say that not that answering your question, but I think I see us starting to forget that a little bit as a country. So I always feel like I have to remind people this was a thing that happened. But during the pandemic, I did a little bit later on, I worked in my capacity as a palliative care doctor and was very busy in that capacity. But in the beginning, in the early part of the pandemic, because of my role at the time in bioethics and also my relationship with the critical care division, I became focused on triage protocols because, in early March, we were seeing what was happening in Europe and looking at our supply of ventilators and being concerned that we would get to a point where we would have to be forced into a triage process. And luckily, we didn't ever run out of ventilators, which was somewhat of a miracle. But we definitely were worried and thinking about what we would do if that happened. And here in New York, there had already been a lot of thinking about that by expert clinicians and bioethicists that had resulted in the New York State Task Force for Life and the Law publishing some guidelines for, they weren't protocols, they were guided, so they didn't have sort of workflows, but they had some delineation of how you would make those decisions about how to steward scarce resources and how to direct them to people who were most likely to benefit from them. And so I was involved in thinking about what that might look like in a protocol, and then luckily was able to stop that work. It got my gears sort of turning about those processes and how they might unfold. So what we did afterwards, going through that experience, I said, well, we have all this data. We have all these patients who came into our institution, and everybody who had been hospitalized and been in respiratory failure was able to be mechanically ventilated, had a ventilator, but we can go back and look at them and say, okay, what would have happened if we had fewer ventilators? So let's say, hypothetically cut the ventilator supply by 50 ventilators, and let's look at by each day which patients would have then, based on the guidance, not been allocated that ventilator. And then we have their actual outcomes and what happened with the ventilator. So we could kind of compare and say, how well did the guidelines do at identifying those who would not benefit and directing the resource to those who would benefit? So that's what we did with our data afterwards and did a study on that. And what we found was that it turned out that there were a lot of people who would have been excluded from receiving a ventilator who ultimately, because they got the ventilator, they did survive. And conversely, a lot of folks who would have gotten their ventilator under the protocol who ultimately did not survive. So it didn't do as well at distinguishing who would benefit the most from getting that ventilator. And in fact, when we ran our models, it looked like it didn't outperform a first come, first served allocation scheme, which at the time was considered unethical because it was assumed that would increase mortality by only selecting people because they arrived at your door earlier and not by how much they would benefit from having that resource. And in some of the models that we ran, not all of them, we did different iterations and making slightly different assumptions in the models. And in some of them, it looked like Black patients who actually survived the pandemic would have disproportionately been excluded from receiving a ventilator more so than the white patients who survived. So there's many possible reasons for that. So one of the things that could be driving that is that that particular guidance from the New York State Task Force for Life and the Law heavily relied on SOFA scores, which is the sequential organ failure assessment score, to make that determination of which patients are so sick that they would die anyway, and therefore you would not allocate a ventilator to them. And we know, unfortunately, that the SOFA scores perform differently in different populations. So that's one of the potential reasons why that score itself would not have been equitable if it had been used. We just had a podcast, so I'm going to cite some of our previous podcasts and encourage people to listen to them. But Khadija Ferryman just did a great job of talking about another example of that in COVID, which is our pulse oximeters, which were used to sort of triage people in terms of how severe their respiratory distress was. And they also perform less well in people because it's measuring the oxygen saturation through the skin, and they perform less well in people who have darker skin. So those are some of the reasons why some of our disparities become highlighted in disasters like the COVID-19 pandemic. And I'll just throw in there one more thing, because I like talking about public health ethics. So the other lesson that didn't necessarily come from my work, but one of the things that we noticed is that a lot of the pandemic planning that had happened before the COVID-19 pandemic really focused on acute care hospitals, because that's where all the action is, that's where it's exciting, and people are being saved or dying, and so that's where it seemed to make sense to focus attention. And as we all know, there was very little attention paid to nursing facilities. So they were very under-equipped. They didn't have PPE. They weren't sort of part of disaster planning. And so that exacerbated the spread of COVID-19. And also, the workers who work in nursing facilities are often women. They're often women of color who are the primary staff. They're often paid lower wages, so many of them work in multiple facilities in order to make ends meet, so that causes more spread between facilities. So it was another way where certain populations were neglected.
Just say the SOFA score and the pulse oximetry, but also, as you say, the long-term care facilities and the people who work in them sort of being neglected is really important. And I remember during the pandemic hearing about this first come, first serve being so unfair, but also hearing about how unfair the SOFA score was. So I think it's very interesting to do that head-to-head and look at those outcomes and kind of highlight where the problems were. And presumably a first come, first serve is just much more straightforward to kind of integrate into a system. And you think all these other complex approaches actually are not any fairer. So kind of shifting gears a bit, you've also been writing about AI, and again, we should refer back to Dr. Khadija Ferryman's podcast last month and her work in this space. But you've also written about how AI could potentially improve health equity. So can you tell us a bit more about that?
Yeah, sure. So, I think I have a lot of concern about AI exacerbating biases because, as she outlined so well, there are already biases in the way that patients are treated in our healthcare system, and AI is learning from that biased data. And so there's a lot of concern about AI amplifying the biases that already exist, and folks thinking about how we can try to mitigate biases and algorithms. And so, my thought is that's great. We should absolutely work on trying to mitigate bias, but can we push it a little bit further? Can we dream a little bit bigger, so to speak? And I actually was excited. This is why I suggested that Dr. Ferryman come on our podcast, because I was very excited about her article in the New England Journal, because she really thought about the biases that are coming through in these AI algorithms as artifact to shed some light, to shine the light on the biases that are existing in our healthcare system. And so it could be a way that could accelerate health disparities research if we're able to use AI tools to demonstrate where these biases are coming into our healthcare system. So that's one potential area to move forward in. And then, if AI is used intentionally to improve workflows and specifically target some of the barriers, the systemic barriers that keep people from getting care, that could be an exciting area as well. And one example is that our institution developed an AI patient navigator that finds patients who are overdue for their colon cancer screening and does some outreach by text to patients. And they have a chatbot that interacts with patients, and they were able to double the number of colorectal screening completions in our population. So it was specifically designed for the population here in the Bronx with input from the community. And so it's a way that we can sort of leverage this technology to expand our workforce and to get people into care. And then one of our medical students here, Natalia De Laval, in her previous job, had written a paper with some co-authors about a chatbot that was embedded with their medical record and did outreach with patients and scheduling. And they actually did some qualitative work, and they found that patients from stigmatized communities or with stigmatized problems, like patients seeking mental health and gender-affirming care, actually liked interacting with the chatbot more because they felt like the chatbot wouldn't be judgmental towards them when they were seeking services. And so they felt more comfortable talking to the AI tool than to talking to a human, which is sad in some ways, but does show that perhaps for some harder to reach groups that AI could be a tool to bring them into care. But all of that would have to be co-designed with communities and really understanding what the community's needs and preferences are to make these tools useful things for them.
Wonderful. So just before we let you go then, you also spend a lot of your time teaching research ethics. How do you discuss bias in biomedical research with those students?
Yeah. So one of the things that I do is I teach research ethics to our clinician junior faculty who are clinician researchers who are going into careers in clinical research. And I think that's a really exciting opportunity to kind of have a multiplying effect by being able to teach people who are going into the field. And I really think that it's absolutely essential for students to know history. And in ethics, we often teach the big scandals in research ethics, like the Tuskegee syphilis study or the Willowbrook studies that many people are familiar with. And of course, it's easy to look at those studies and say, well, this was terrible, like what people did in these studies was completely unethical, and we kind of tend to distance ourselves from it, like, well, that was just a couple people who made wrong choices, right? But I think what's missed is a subtler but more insidious way that biomedical research has, for the most part, over the course of history, reproduced, bolstered, and sometimes generated racist ideas about biological differences between groups. And I'll just give one example. I worked with a historian, Christopher Willoughby, who taught me a lot about medical history and opened my eyes to a lot of these examples. And one that I find striking is the U.S. Sanitary Commission. So after World War II, the U.S. Sanitary Commission, it was basically the grandfather of all population-wide epidemiology studies in the U.S. It was the first time like the federal government got really involved in epidemiology. And so what they did is the U.S. Sanitary Commission collected reams and reams of data on soldiers for all sorts of things. But one of the main things that these researchers were interested in was looking at phenotypical differences between Black and white Union soldiers. And they were measuring height, they were measuring lung volume, they were measuring weight, they were measuring head circumference, the length of their arm span, all sorts of different things. And of course, they found many differences in their measurements between these two populations. But that's because the Black soldiers had just survived slavery. Many of them had just joined the Union Army after escaping slavery. And so that was data that was so obviously confounded. I mean, it's almost like laughable. But the researchers very specifically positioned themselves as experts in racial differences. And they meant for their work to inform social choices about how to integrate the newly freed Black people into society. So it was pretty racist. But what I teach we kind of go through a number of examples across history, and I point out that some of the reification of racial categories persists in areas like precision medicine. So, we just had that podcast with Daphne Marchenko and Sam Trejo, who are really parsing out this exact issue in their episode. And so I want to instill in my learners who are budding clinician investigators that ethical errors in research aren't just about these big scandals, but they're also the ways in which we can be blind to our own biases and inadvertently develop studies that at best point us in the wrong direction and at worst can actually hurt people. And I think this is an important piece that should be taught in all research ethics curricula, because it's a big ethical error to use biased thinking to design studies that will perpetuate these kinds of issues in society. So that's a really sort of gratifying area of work for me.
Excellent, interesting, and as you know, you're going down my wheelhouse. This is what my specialty is. But it's all interrelated and interconnected, and hugely important on trying to alleviate as much as possible as we can health disparities. And again, we thank you for your time. It's awesome that our listeners can get to a little glimpse of what you do, other than, of course, helping us continue the work of the podcast, but also what you do on a day-to-day basis. So we are deeply appreciative of your time, of your work, of working with you throughout the past few years. And this is Dr. Liz Chuang as well, or Dr. Elizabeth, as we call her as well. So thanks again so much for sharing.
Thank you. And, you two are really the heart and soul of the podcast. Without the hosts, there would be no bioethics in the margin. You're really there month after month coming up with researching the guests, coming up with the questions, having the conversation flow. And so, I really am just in the back doing organizational things, but you guys do the hard work. So thank you for that.
Thank you for listening to another great conversation on bioethics in the margins. This podcast is hosted by Amelia Barwise and Kirk Johnson. Our producer is Elizabeth Chung. Our editor is Madeline Mahoney. Our theme music was written and produced by Pablo Cortes. And we are grateful for the assistance of Veda Coda. Join us again next time.